Broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for joining us today in this first ever annual conference of the CNM. My name is Nicolas Rondeau-Lapierre, and I work for les Éditions Multiconcept. In the background, you won't see him, is my good colleague Eric Thibodeau, helping us with technical support today. We will give another minute of waiting time for people to join, because sometimes it takes a little bit of time. So please be patient, and this is a word you're going to hear today, patience, because it's obviously not just one fluid motion. Once we give the rights away, it's always a 3 or 4 second delay. So please be patient with us. So we'll go ahead and just wait 1 minute for all the attendees to join. All right. Well, while we wait, I will go over a couple of cues today that is important to make sure your virtual experience goes smoothly. I will ask you to familiarize yourself with the control panel. For those who are not familiar with these kinds of software, so a control panel it showed on your right-hand side. So right off the bat, I'm going to make sure your audio is working. You can do that in the audio section. There is an option to call in also if your microphone for some reason or your headphones are not working. You can decide and you can click on audio phone call and it'll give you a phone call and you can join that way. Next one will be that you are muted. You can see you cannot unmute yourself, only us can unmute you, and that will be in the Q&A if ever someone would like to speak. In the handout section, please feel free to download any kind of handouts that is available to you. There will be multiple flyers for the sponsors exhibit. Right now we have the program in the handout section, so please feel free to download it if you need. Questions. If you do have any questions, you will see the question mark icon. This is the way you're going to be able to ask questions to the presenters. There is an assigned Q&A period after the presenters are done with their presentations. You will interact with the assigned moderators. Please feel free to ask any question at any time, and then we'll go over all the questions in the Q&A period. If you have technical problems, same process. Please feel free to tell us in the question section, and we'll get right on it and try to fix the problem. So with that being said, please enjoy today's session. This morning's session will finish around 1:45, and then we will go ahead with the sponsors exhibit. So no further ado, I will present to you today's moderators, Dr. Urbain and Dr. Ross of the CANM. So please, you have the floor. Have a good day, everyone.
Good morning, everyone. I'm Jeanluc Urbain, and I have the privilege to work at Wake Forest University down in the United States. I'm still very much involved on the Canadian scene. I'd like to thank you all for attending this first CNM virtual conference. As you know, it's a very difficult year. And we at the office and with your help and the help of the board of the CNM, we have worked very hard over the past few months to switch from a live meeting that we all enjoy, that we would all have to have. It's not possible, so we work very hard to organize virtual conferences and virtual webinars. Thank you for participating today. Thank you for your support. I'd like to acknowledge the tremendous work of Helen Sanson, who is our executive director of the office, and also the challenge that Nicolas, Eric from Multimedia Concept decided to take on to help us organizing these virtual conference and webinar. Today's program will talk about the present and also the future of nuclear medicine. We're all very excited about this program, which was put together with the help of the scientific committee that you see here on your screen. I'm very lucky that my dear friend Andrew Ross, who is the immediate past president of the CANM, when I spoke to him a few months ago, we brainstormed and we said, why don't we start organizing this together? So I'm very blessed that Andrew is with us today, and that he and I will try to take you to this new virtual exciting nuclear journey. Andrew?
Thanks, Jean-Luc. That's great. I really appreciate it. And I appreciate everybody coming in here on a Saturday. I call this third time lucky. We had Ottawa in April, Ottawa in the fall, and finally we're going across Canada in November. So I hope everybody gets a lot out of today. I just wanted to say a couple of other thanks. I wanted to thank the scientific committee of the Canadian Association of Nuclear Medicine, and particularly the chair, Dr. Urbain, who pulled together this program. It's been a dynamic process. We've had very, very obliging speakers who've been redeployed several times as we move forward with this. I also want to say that, as everybody is saying, this is our first go at a real full day conference. We had our webinar that Dr. Urbain lectured on cardiac amyloidosis about a month ago. That was very well received, and this is an expansion on that. I want to say that there will be feedback forms that, in order to get credit for the day, that will need to be filled out, and those are very valuable as we try to do this, because we will be moving forward with more virtual sessions through the winter and into next spring, because we don't expect anything different in terms of the ability to gather as a group. I also want to thank our sponsors who've made this possible as well. At lunchtime today, there will be a sponsor forum, and I hope many, if not all of you, can join that as well, because that will be a very interesting session on its own. Without any further ado, I'm going to introduce our first speaker, Helena Zetterberg from the UK. She's going to talk to us about personal dosimetry and Thermognostics. She's a very, very accomplished clinical scientist in the UK with a very special interest in nuclear medicine. When you look at her bio, you can see she's had a lot to do with GFR work over the years and helping to optimize that. But most currently, she's the principal scientist with the Barts National Health Trust in nuclear medicine and PET-CT, obviously with a strong interest in what she's going to be talking about today, and also works as a Hermes clinical applications specialist. So without further ado, I'm going to bring Helena in from the UK, and look forward to a very interesting discussion. Thank you.
Hi, I think everyone can hear me now. Is that true?
Yep.
Hello. Okay. Are you seeing? Great. Thank you. Are you seeing my presentation?
Yes.
Yeah, it should be just the first slide: dosimetry concepts to practical solutions.
I'm seeing a computer screen, Helena. It's a.
Okay.
It's the GoToWebinar. I'm not seeing the slides at this point.
Okay, so it's shared the wrong screen. Let me see if I can just move. Could you stop me sharing and then ask me to share again, and then I'll try and share a different screen?
Yep.
Are you sending the link to share the screen? Okay, here we go. Share the screen. Okay, how's that?
You're great.
Okay, so you can see dosimetry concepts of practical solutions, the presentation.
We're good to go.
Perfect, thank you. Hello, everybody. My name is Helena. Thank you for that introduction, and thank you to the organizers for this opportunity to speak at the CANM virtual conference. So I have two jobs. I work part-time as principal physicist for St. Bart's Hospital in London. I also work as a clinical applications scientist for Hermes. I'm going to talk today about dosimetry. This is my disclosure. So as stated, I am employed part-time by Hermes Medical Solutions. So today we'll look at what is the point of doing dosimetry. We'll look at the foundations of dosimetry, which is quantitative spects. Then we'll look at various different methods of doing dosimetry, and then we'll briefly look at the Hermes voxel dosimetry program, and then Thermognostics. So first of all, why dosimetry? So the main reason is to optimize the treatment. So we want to make it effective. I'm going to do quite a lot today of comparing with external beam radiotherapy. So an external beam radiotherapy, an oncologist would say, I want to treat that tumor with 60 gray of radiation, and I know that that will kill the tumor, kill the cancer cells there. But we have none of that information in nuclear medicine. So when we give patients these therapies, we don't really know the benefit to them, which is not a good situation to be in. So we need that dose-response relationship to be sure that what we're going to be doing is beneficial and not harmful. So lots of these treatments are nephrotoxic, for example, and we need to make sure that we're not going to do more harm than good. Also, we need to make the best use of resources. So these treatments can be very expensive. We must know the benefit to the patient before spending this kind of money on treatments. So let's do that comparison with other radiation treatments now. So looking at external beam radiotherapy, it's delivered using high energy X-ray beams, which are precisely targeted onto the tumor. You can see an example in the pictures here of a planned treatment of a prostate, I believe. And there's the dose volume histogram that they use to assess whether or not the tumor is well covered by the radiation. So the X-ray beams can be turned on and off and shaped to ensure the tumor is well covered, and also to avoid any adjacent radiosensitive structures called organs at risk. There's specialized software to predict the dose and optimize the radiation delivery. There's also years of this published evidence material documenting the dose-response relationship. So for different types of cancers, they know exactly how much gray to deliver over what time scale to kill the tumor cells. So the oncologist really knows the benefits of the patient when they're sending them for these therapies. There's also brachytherapy. So brachytherapy is where sealed radioactive sources are placed into body cavities or directly into tissues. The dose can be predicted using planning software to maximize the damage to the tumor tissues. So we've got a plan on the right-hand side here, so we can see the positions of where all of the catheters will be introduced with the sources, and they will dwell in certain positions there for a certain amount of time, as planned by the software to deliver a very precise and exact amount of dose to treat the cancer. Yeah, so we've got specialist software to help with this. So molecular radiotherapy, why is it so difficult? We've seen two instances there of very well controlled and well planned radiation treatments. Why can't we do it in nuclear medicine? So part of the problem is the way that we deliver the treatment. So the radiopharmaceutical is delivered systemically, making use of a biological process to irradiate tumor cells. So maybe it's gone into the bloodstream, and then we're relying on receptors on the tumor to take it up. Or you can selectively deliver the radiation. For example, a CERT, you would deliver the radiation into the liver vessels to supply those tumors directly. There is no on-off switch for radiation. Once it's there, there's nothing we can do to change the amount of time it's going to be there for. So to plan and evaluate the dose delivery, we need to know, crucially, how much activity is present in the tumors and for how long it is going to be there for, and any organs, of course. We need to know how much energy is deposited in the surrounding tissue by the radioactive decay. We need to know how close it's going to get to the radiosensitive organs, and we need to know the biological effectiveness of the radiation dose. These difficulties mean that the development of planning and treatment delivery for molecular radiotherapy lags as much as 30 years behind external beam and brachytherapy. And only recently is specialized software now available to help with this planning process, which we'll talk more about later. But next, so first thing I'm going to talk about is the sort of technical underlying thing that we need for all of this, which is quantitative spect. So that's answering the first bullet point of what we need to know, how much activity is present in tumors and organs. So let's move on to quantitative spect. So with quantitative spect, the idea is that we're going to reconstruct spect data with voxel values in becquerels per mil or an SUV. So that means that we can know when we look at the voxel, we can say, yes, there's this much becquerel of lutetium in that voxel, for example. To do this accurately, we need a reconstruction algorithm with accuracy compensations. So CT attenuation correction, scatter correction, of which Monte Carlo is the best method, and then resolution recovery as well. And I'm just going to talk briefly about each of those. So CT attenuation correction, we can have this bilinear model that takes the Hounsfield units on the x-axis of this graph here. So that's what your CT scanner is directly measuring, and it converts those into linear attenuation coefficients. And in that way, you can simulate, or you can work out exactly how photons emitted in the patient are going to be attenuated on their way to the detectors, and make a correction for that. Scatter correction is the next thing. So this Monte Carlo method of scatter correction is much more accurate than doing the more traditional energy window-based scatter subtraction. But Monte Carlo scatter correction is quite a challenging thing to do because it depends on several factors. So it depends on the activity distribution in the patient, the attenuation map, by which we mean the CT, the camera energy resolution, and the energy window settings on your gamma camera acquisition. So an algorithm that can do this, so this is scatter inside the patient, you can simulate during forward projection in the OSEM iterative loop with Monte Carlo modeling, and you can force the photons to scatter towards the detector. If you'd like any more information on an algorithm that works to do that, then I've got a couple of references there that you can look up at the end. Resolution recovery. So we have the standard Gaussian model of resolution recovery. So this is the familiar concept that the further away your gamma camera head is from the patient, then the worse the resolution is going to be due to this geometric relation with the point of the source point and the detector face. So the image blur contributes. We've got the gamma camera intrinsic resolution and the finite size of the collimator holds. And so we can model that response during the forward and back projection steps. So we're able to convolve the reconstruction voxel with the camera's point spread function before we do the projection. So what we need to know for the Gaussian model is the full width half max of that point spread function, which depends on the camera resolution, the collimator hole length and diameter, and the distance to the front face of the detector. So the way that software can do this, the way that spec reconstruction software is able to do this calculation, is that the first three things there in the bullet points, we know that for every camera manufacturer, we can just put into the software what the resolution is, the hole length and the diameter of the collimator, and the distance to the front face. That is saved in the DICOM header of the raw spec data. So there'll be a field that says at this spec stop position, it's this distance. At the next spec position, it's this distance. So we can just make that calculation all the way around the patient with that information from the header. But that Gaussian model is only really effective when the collimator is effective. So if we're getting, so for technetium, it's really good. But when the collimator is not being so effective, when you've got lots of septal penetration, for example, I123, I131, then we need a more advanced model. So we have, or Hermes have this special Monte Carlo model of collimator interactions. So in this model, we're simulating all four photons that you can see in this picture. So photon A is a good photon, that's correct, that's being collimated well. Photon B is being scattered off the collimator septa and then detected, so that would be misplaced in the image. photon C is being absorbed by the collimator sector, and then a KH X-ray is being emitted, and D is just going straight through the collimator. So we can simulate all of these interactions for particular radionuclides and get a much better points per function for them to use in that iterative loop. So it's much more effective for I123, I131, and yttrium-90, where the collimators tend to struggle. So just a nice publication here that demonstrates the differences between these kind of reconstruction methods. So we can see this is looking at I123 and I131 for that Monte Carlo based scatter and collimator model compared with the standard triple energy window there. And you can see in the phantom images, you can see in particular with the Monte Carlo modeling, it's the background that is much improved. So you can see the background is cooler in that image compared with the others. And the recovery coefficient on the graph is best for the Monte Carlo modeling of the collimator. So the full interactions then have been taken into account when doing the reconstruction. But you may say, doesn't resolution recovery cause artifacts in the image? What about these kind of Gibbs-like artifacts that you might see? So in the image here, you can see on the right, you kind of got this sort of ring, which makes it look like the middle is cooler. You've got a sort of cold spot in the middle surrounded by a ring. And the reason that this happens is because resolution recovery tries to recover the fine detail in the image lost to low spatial resolution. But that correction is not perfect. So at edges, particularly at very high contrast edges, such as you get in phantom scans in particular, but also in the patient sometimes, you get these edge over and undershoots, which can cause this, this overestimation. And so we can get around that by using a different type of reconstruction algorithm. So rather than OSEM, we can use a Bayesian reconstruction. And the way this works is basically we're applying penalty factors, or applying constraints to the reconstruction problem. So we can reduce the over and undershoots by favoring images whose adjacent voxel values are close to each other. This is quite effective at suppressing noise, and it can also reduce the artifacts. So we can see I've just got a little diagram here of the iterative loop. We put in these the penalty factors are multiplied by the guess of the reconstructed image to try to get them into the loop rather than using a filter afterwards, which also takes down the resolution. We can involve it in the iterative loop itself to take those edge overshoots off. And just to look at some images that these algorithms can produce. So on the left-hand side, we've got OSEM with no resolution recovery. Then we have OSEM with resolution recovery, and you can see the profile there is through the biggest sphere. So you can see the sort of Gibbs type artifact. Then we've got 3 different types of Bayesian prior to do this kind of smoothing, and the kind of quality of the image they produce, the texture of the noise is a bit different from what people are used to. But it can be very effective, as you can see. Just to look at a patient image with those same reconstruction algorithms, it does effectively reduce the resolution recovery artifacts, but because the texture of the image does look a bit different, so particularly the AMAP there, that's using the anatomy, the CT, to try to guide the smoothing. So it basically says where you can see similar Hounsfield unit voxels from the CT, they should be similar spect intensities. That you get a strange kind of looking image. It's like a hybrid between a spect and a CT. So I think people reporting these images don't really know how to interpret that because it looks so different from what they're used to. But hopefully it might get them in future. Just to finish off this section with a look at what these spect compensation corrections actually do. So looking at a technetium, we've got a cardiac scan here. So in the top left, we are seeing no compensation. The top right here, so we've got attenuation correction applied. The main difference you can see here is that the lung background is much reduced because the low attenuating lung tissue is being taken into account for here. When resolution recovery is also applied down here in the bottom left, we can see that the walls of the myocardium are much sharper now than they were before. And with the scatter correction as well, the main effect this has is to reduce the background. So particularly inside the left ventricle here, you can see this is much darker now than it used to be. So we can see that these photons that were inside here were purely just scattered in from the hot myocardium walls. So that's the scatter correction has done well to take those out then there. Then the last step. So now we're confident that we have an accurate activity distribution in our reconstruction. Now we just need to know a sensitivity factor to apply. So we can do a camera calibration phantom scan. So we can do a uniform phantom of a known activity concentration. And we scan that on the same camera with the same collimator, radionuclide, and reconstruction protocol that we're going to use to scan the patients. And we can get a sensitivity factor in CPS per megabec that we can then apply to our reconstruction to get the voxel values in becquerels per mil. And some of the images. So we look here, so we've got the Symmetry application. So we're looking at day 0 and day 1 here from lutetium dotatate SUV spect reconstructions. Thank you to the Queen Elizabeth Hospital in Birmingham, UK for these images. So looking at day 0 and day 1, we can see how the activity is changing over time in this patient, and that forms the basis then of doing dosimetry. Because I said, not only do we need to know the activity present in the tumors and the organs, but we also need to know how that changes over time. Okay, moving on to methods of dosimetry. So looking first at the Meld model of dosimetry, or Linda EXM. So this is probably what most people are familiar with. It's the model that's been around for the longest time. So in this model, standardized models of human anatomy are used. So we've got the adult male and female, 15, 10, 5, 1-year-old, newborn and pregnant women, 3, 6, and 9 months. So this is a really crucial aspect of this model, is that you're not using your patient anatomy. It's just these models that are available. So you have to just pick the one that is closest to your patient. The way it works is that you input into the organs of the model, you say the residence time of the radionuclide that you're using. So you would take that, you'd calculate from your images, from your quantitative spect images, you know that you've got this much activity at this time, then a bit more later, then a bit less. You integrate that to get the total amount of disintegration, the total amount of decay that's happened in that organ, and you put that residence time into the model to say, okay, into your adult female model, put this much into the liver. Then the model uses something called an S factor to calculate both the self-dose to the liver and the cross-dose to other organs. So it knows, in that model, it knows how far away all the other organs are from the liver, and it can calculate the cross-dose expected. So some pros and cons of this model. It's quick and quite easy. It can be done with planars only, which can be good depending on your imaging possibilities in the department. It can be extended to voxel level as well. Crucially, some cons: it does not use your patient anatomy. It also assumes a uniform activity distribution in the organs. It reports an average dose only. This is a pretty major con in comparison with external beam. So external beam like to talk about so the dose, so the dose volume histogram for what they make, and that you need voxel level dosimetry for that. They like to talk about the dose given to 90% or 95% of the tumor. So it's looking at the actual coverage of the tumor by the dose, and not just the average. So that's quite that's not what radiotherapy would think good enough to report a dose on, just the average dose. Also, this model does not include tumor dosimetry. So these models, these healthy human models, do not come with tumors in them. They just come as healthy humans. You can simulate tumors with a simple sphere model only, but that sphere is just in space, and you can't do any cross-dose calculations with it. It's developed for radiation protection, not for patient-specific therapy dosimetry, really. So that's part of why the tumors are not so well handled. So the next level, voxel dosimetry, a dose conversion factor. So we're going to get gradually more and more complex going through these methods. So what we do here is we take the absorbed dose distribution, so that would be our quantitative spect. We multiply each voxel by an activity, so I multiply each voxel by an appropriate dose conversion factor, DCF. So we know, for example, that we're using I131, and we've got this much I131 in this voxel, therefore just multiplying it up by a certain number, this is the dose to that voxel from the I131. It assumes that all emitted particles from the I131 are absorbed locally, and there is no crossfire dose. So pros, it's quick and quite straightforward. It can under and overestimate dose due to the lack of crossfire. That's a fairly major drawback of this model. So the next logical step is the dose point kernel. So the dose point kernel describes how a point source of activity distributes energy to its surroundings as a function of distance. So you've got this kind of nice central where you've got lots of activity in the voxel that it's centered on, and then as you gradually get further away, the amount of activity gets less and less, or the amount of dose deposited gets less and less. So you would convolve your activity distribution from your quantitative spect with the DPK to obtain the absorbed dose. This is more accurate, as you are taking into account the crossfire dose. But there are issues. So it's computationally quite intensive. The results are voxel size dependent. You need these pre-existing dose point kernels already calculated, which generally requires a Monte Carlo simulation. You get errors near the tissue density boundaries due to only the DPK being counted for one tissue only. So an example of this is where you've got a tumor in the liver, but it's very close to the top of the liver where you've got lung tissue as well. So if you put a DPK for the liver onto that, you would be treating the lung as if it were also the same density as the liver. And that can lead to a fairly major inaccuracy in the dose calculation in that lung area due to that. Also, it introduces additional blur to the inherent blur from the imaging process. So the way to imagine this, if you've got your quantitative spect, which especially if it's an I131 is already pretty blurry, and then you're convolving this this kernel for every voxel, the whole thing just gets like a lot more blurry after that. So now we've got the top gold standard of dosimetry, which is a full Monte Carlo model. So absorbed dose distribution calculated from your calibrated spect using detailed physical interaction probability libraries and repeated random particle history simulations. This is the most accurate. This is the best we can do for dose calculation. Computationally, it's very time consuming. Generally, in the past, it's been impractical for a clinical setting. The simulation parameters can be cumbersome to set up. This has meant that it's been an academic area only until recently. This picture, by the way, is the Large Hadron Collider at CERN. This is not a patient, but just an idea of what a Monte Carlo simulation would actually look like. So Hermes, the company that I work part-time for, has a program called voxel dosimetry, which does do a Monte Carlo simulation of the photons. So the workflow for using this application is you acquire your quantitative spec CTs. So in this example workflow on the left-hand side, we've got four spec CTs at the top here. Then we would do the reconstruction to get a quantitative spec. So we know every voxel value in becquerels per mil. Then we would do a co-registration between all of those time points to make sure that we're looking at the same voxel through time. We would do the integration through the voxels to get the total activity over time, and then the dose simulation. From that we make a dose map. So the dose map is something that looks a lot like the spect, to be honest, but it's in units of gray. So we know then for every voxel what gray we have in that voxel, and then we can do some analysis on that dose map. So make a dose volume histogram, like radiotherapy would be looking at. Or of course, we can also just visually see the isodose contours then on the dose map too. So a bit more detail about that. So one of the steps in that dosimetry calculation is the activity integration. So the way that the Hermes program works, it does a trapezium rule integration for each voxel through the time points. We're assuming instantaneous uptake. So the this point here is extrapolated back to the y-axis using just a physical decay correction. And also a single exponential extrapolation is fitted from the last 2 points. Now this is the really innovative thing, is the photon Monte Carlo. So this is the full-blown Monte Carlo simulation that you would have in an academic setting. But in the Hermes program, it has been optimized to be able to run in what normally finishes in under a minute, normally under 30 seconds for clinical use. So we're using the photons being simulated through the CT map that you provide for your patient. And the XCOM photon cross-section database is used to sample the interactions in the tissue. So that's the photon part. The electron part is done with a local absorption model. So that's just the dose conversion factor, because that significantly speeds up the dose calculation. So the activity distribution is just multiplied to an electron dose distribution by using this dose converting factor. And then you add the two contributions from photon and electron together to get the dose map at the end. It has been validated for lutetium compared with Olinda for kidney dosimetry. There's a lot of publication on this. In fact, it was the subject of a PhD thesis to check all of these calculations and also to compare with full Monte Carlo as well to see the difference there. Okay, Thermognostics, what have we got? So the definition of Thermognostics is just to use the information from medical images to determine the optimal therapy for an individual patient. So this is something that everyone is probably already doing for radionuclide therapy. So the patient has just one scan, say for example with, I think this is a PSMA, gallium PSMA PET scan here on the left-hand side. And whether or not you can see uptake there would dictate whether or not the patient goes on to lutetium PSMA therapy. But in molecular radiotherapy, we can go a step further than that. We can use the diagnostic version of a radiopharmaceutical to actually predict the absorbed dose that you would get from the therapeutic radiopharmaceutical. And that way we can ensure a safe and effective treatment. So some examples here, it's possible to use I-124 PET to do this for I-131 sodium iodide for thyroid cancer metastases. You can use indium-111 or yttrium-86 for lutetium or yttrium-90 dose peptide treatments. Or you can even give a low dose of the therapeutic radiopharmaceutical itself, so for example, 200 megabecs of lutetium to predict what treatment you're going to get. So the workflow for doing that would be to carry out the pre-therapeutic imaging in the same way that you would do with the post-therapeutic imaging to calculate the activity distribution and the kinetics that you're expecting. Then you assume exactly the same behavior for your therapeutic radiopharmaceutical, and then you can scale the activity that you give of the therapeutic radiopharmaceutical to achieve a target dose to a particular tumor, and also to limit toxicity if that's the main limiting factor for the patient dose. Okay, we have got to the end. So in summary, I've talked about why we need dosimetry, talked about quantitative spect and different methods, pros and cons of different styles of dosimetry calculation. I briefly looked at the Hermes voxel dosimetry program and then some Thermognostics information as well. These are some references, and yeah, that's the end.
Well, thank you, Helena. I really appreciate you taking the time with us here today. It worked really well from my standpoint. Fantastic presentation. The slides were seamless and very, very interesting. Whenever nuclear physicists start to talk, you always get a little concerned, but you did a fantastic job of communicating very, 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 very tough, and I know have simplified it tremendously for the dumb docs like me. Whenever I hear about Monte Carlo, it always is a bit of hair stirrer, as I am sure it is for many of the people. One thing we did not do as strong as we should have at the outset was talk a little bit about how we will hope to have a good interactive question session after each of our discussions today. There is a question opportunity to submit questions. There's been a couple of technical questions, but there's been no questions yet submitted in terms of subject content. What we're hoping is that you can, as you go along through the lecture, if you have a question, just pop it down. We're going to be tracking and trying to keep those organized so that we can make the question and answers flow when they come, rather than just saving all the questions for the end, because if everybody starts throwing questions in a little bit of time, it can be a little bit tumultuous for those kind of receiving them. So I guess I will give you folks a couple seconds to gather your thoughts. I know this was a very, very complete talk, so it may be that the questions have all been answered. But I wanted to ask you, Helena, how long do you think it will be before these concepts find themselves into what we would call the mainstream, day-to-day nuclear medicine department? I mean, and they're certainly showing very elaborate modelings and very interesting results, but just in terms of the practical implementations.
Yeah, it's a good question. I think it's something that everybody is struggling with, really. I know in Europe there have recently been some legislation changes which mandate that you must do this kind of dosimetry for certain types of therapy. Hopefully that will see a change and people will do it. But I mean, the difficult thing really is the number of visits required for the patient. And that's the thing, is that, to get that, the way the activity changes over time, you might need a patient to come back for maybe 3 visits over the course of a week. And that's just not practical in some hospital settings. Maybe if the patient has to stay in a ward bed for all that time in a shielded room, like, it's just not, people don't have those facilities. So I think trying to get everybody to do this in this kind of situation is near to impossible until we can have the ideal is single time point dosimetry. That's what everybody wants, because we're already doing that single time point image as standard of care normally after the therapy is given. So if we can use that for the dosimetry, that would really be a good step towards getting it mainstream, I think.
You think we're close to that holy grail?
There's been some research recently into it, I think, which says that the inaccuracies that you would expect from that are perhaps tolerable. I think that's the thing. It depends on what the uncertainties you're going to get and what the errors are, and if that's good enough. I mean, it's better than nothing, surely. Is my view.
I've got a question here come in from one of the participants. Just a comment to start with. Very interesting presentation. The question is there any other application in clinical use of SUV spect apart from the Thermognostics, or do you see spaces for that?
Yeah, certainly. I should have had my slides from a different talk for this. Okay. Yeah, there's some really interesting work going on. So there's a really nice study out of a Finnish group recently which compared technetium bone to fluoride PET scans, and looked at the SUV in the bone fluoride PET scan and compared it. Basically, very good correlation with the technetium bone SUV, which was just a nice result. Also means standardization as well. Like if you want your patient to be able to come back and have a similar scan at even different hospitals, then we really need to know the sensitivity of the spect that we're giving them. So I think it's nice from a standardization perspective, clinical trials that might go across multi-sites, and you want to do perhaps dosimetry, but you just want to do uptake measurements, or you want to be sure that the image that you're seeing is going to be comparable between different hospitals. I think it's important to be able to standardize your spect recon for that reason too. And also just general follow-up as well. So if you had a patient who was coming back after a treatment, sometimes you have the kind of normal thing that you have to try to just adjust the window level to equalize the background. I think normally people try to just do that by eye. If you had a quantitative specs, then you wouldn't need to. You just say SUV of 20 or whatever, and that would be your comparison right there, and you'd be able to trust the change in uptake from that, rather than trying to make a judgment. Because sometimes if the patient has a different bladder filling, you get different top level of the window, and it can be very hard to decide.
Very true. Yeah, interesting. Another question's popped through, very pertinent. Are physicians typically involved in dosimetry planning in the UK and Europe, or is it all done by the physicists and other staff?
Yeah, good question. It's hard for me to answer that because where I work in the UK, we don't have much clinical dosimetry happening, much to my shame. I wish we did have more. I understand that in Germany, it is much more sort of clinically widespread. I mean, I hope it's the case that the physicians have lots of input because really it needs to be the doctors that they're asking for this and then seeing the benefits as well, because that's in the analogy with the oncologist prescribing a certain treatment for their patient for radiotherapy. That's what we need. That's the information that we need to be able to provide the physicians with, is that if you, for the MT discussion, they can say, if we give this patient a lutetium PSMA treatment, we can expect this kind of response. That's really where it needs to be. That's the true utility of dosimetry, is being able to say that. So yeah, it should be an multidisciplinary team approach for sure, with the doctors having a very important role.
For sure. So just in terms of the, you alluded to the UK being a little slow at this point. Are there countries in the European model that are using this fairly extensively?
Yeah, my understanding is that Germany are quite far ahead for this.
Yeah.
They do, lutetium therapies in particular. They're using proper dosimetry for that.
From my understanding as well, we missed being able to have the European meeting in person this year, of course, because that's when you get to see some of the fascinating stuff that's going on there. That we're a little behind the ball in here in North America. I'm just giving the attendees another couple of seconds here for any further questions that you may have.
Andrew, can you hear me?
Yes, we can, JL.
So I have a question, if I may, for Helena. Helena, I think that this is, thank you for your presentation. This is great, and hopefully we'll get the impetus to expedite all of it, the dosimetry in North America. The question I have for you is this: is there clinical study ongoing in the UK? I'm assuming in Europe they might have started to show correlation between the dosimetry and the clinical outcome, because at the end of the day, that's the most important thing.
Yeah, absolutely. So there is a study in the UK that I'm actually involved with helping. So the sites, Birmingham, that I mentioned before, who provided those images of day 0 and day 1 lutetium dotatate quantitative spect, they are doing a study where they've managed to, as their clinical routine, they've managed to get the patient to come back for 4 visits for a spect at each visit. And then from there, we're going to try and engage with the oncologist and get enough clinical follow-up on these patients to really get that dose-response relationship. So even though we're not, we're still going with the standard activity prescription, so we're not using the dosimetry to prescribe the treatment. We are measuring the dose and trying to say from the patient follow-up whether or not it was effective at treating the tumors.
Helena, I have another question which is more technical, and probably only a physicist can answer to that. You mentioned about dosimetry using iodine-124. That's the PET domain, and it's easy to understand that on a quantitative point of view, PET is much accurate than spect. The trend now in the spec world is to move from sodium iodide and photomultiplier to semi-solid conductor like CZT. I'm assuming that you have seen the spectrum dynamic cameras, and I'm assuming that other vendors are also moving into that direction. Do you have, I'm assuming you might not have much experience with that, which type of physics challenges do you anticipate switching from a sodium iodide and from a PET quantitative perspective towards a semi-solid conductor in spect in terms of dosimetry?
You're right, I don't have much experience with the new style of the CZT cameras. But I think a general comparison of PET quantitation and spect quantitation is that there is no reason why spect quantitation cannot be as accurate as PET quantitation. Like the quantitative aspect of PET is kind of built into the camera and done as part of the reconstruction on the scanner. But it's exactly the same concepts as we would have in the spect. So if you have a reconstruction algorithm that has all those accuracy compensations built into it, then you can achieve still very good quantitation. And you're always going to struggle with the count rate. I mean, PET's a lot more sensitive, so the quantitation that you'll get from that is more reliable. But there's, yes, spec can achieve some very good quantitation. And I mean, that should only really increase the more sensitive the cameras get, the better the accuracy should be for these quantitative measurements.
Thank you.
Thanks, Dr. Urbain. Well, I think we will wrap up this session. It seems that everybody's questions have been answered, and certainly a very, very comprehensive and interesting talk on a very topical subject. Helena, I really, really do appreciate, on behalf of the Canadian Association of Nuclear Medicine, you taking time from your day.
Oh, no problem.
I wish you all the best. I know things are tough over there now, and particularly tough by the sound that what's going on in terms of lockdown again. And I hope it's relatively short-lived, and that by Christmas things are a little bit more relaxed. You take care, and thanks again.
Thank you.
Thank you. There we go. I think at this point I will hand over the discussion to Dr. Urbain for a few minutes to take on the next conversation.
Thanks, Andrew. I hope you appreciate the in-depth review of the opportunities and challenges that we face in terms of dosimetry. My own personal view is that we definitely need to get involved into that, better understand, and definitely establish outcomes based on the dosimetry information, dosimetry data. We at the CANM, and I'm assuming the other societies and association of nuclear medicine and in general, are very attentive to respect and the neutrality, or make sure that we don't have any major conflict of interest. We could not do our work without our industry partner. Without equipment, there's no way where we can practice nuclear medicine. Without radiopharmaceutical, without software company. So we try to have a little bit of a balanced approach. It's all tough within one day virtual session to have all the industry player involved. So during the course of the years and in the future, we'll make sure that there's a balanced view and a balanced perspective which are presented by our industry partner. The field of nuclear medicine, some technology has evolved tremendously. If you think a little bit about it, the first spect CT came in the late 90s, and then we have the revolution of PET CT. Now we can discuss about PET-MR, artificial intelligence is here. So we reached out when Andrew and I and the others carved out this program. We reached out to the industry partner like Hermes for the software, like GE and Siemens for the equipment, and we asked if they would be interested to give us a little bit of an update in terms of where the field of nuclear medicine is going on their point of view. And we are lucky to have today the global clinical application leader for molecular imaging at GE Healthcare. Gil Kowalski, Dr. Kowalski joined GE in 1999, and he holds a master's degree and a PhD in biomedical engineering degrees in pre-med and computer science. I didn't know that existed, but that's great. So he's definitely more than capable to understand what the needs that we face in nuclear medicine. Without not only the healthcare professionals specializing in nuclear medicine, but our industry partner, we would not be able to develop the field. So Gil has accepted to share with us his views, and I'm assuming what GE perspectives are. As I said, in the future, we'll make sure that we have a balanced approach across the field of nuclear medicine and the industry partner. I believe that Gil has put together a video to show us. So I will basically turn and ask Nicola to move forward, activate that video, and I will reconnect with you at the end of Gil's presentation for the question and answer. Gil will be available to answer directly your questions. So thank you very much and enjoy Gil's presentation.
So thank you for the invitation and the introduction. My name is Gil Kowalski. I'm the Global Clinical Leader for GE Molecular Imaging Division. I started my journey with GE actually in molecular imaging many years ago, and currently I'm focusing on the spect, PET, and digital technologies. What I would like to do today is present some of the recent technologies that have been developed and the ones that are still in development. I'm obviously biased as a GE employee, but I will try to avoid the commercial aspects of the technology I will discuss and keep it as technical as possible. Some of the technologies that I will present are not commercialized yet and still in development phase. So I'll basically follow in this talk today three main things on spect, PET, and in the digital domain. And for the spect, I'll talk about the acquisition part, the CZT detectors. For the PET, I'll focus more on the image generation, and in the diagnostic space, I will discuss AI opportunities. And let's start first with cadmium zinc telluride, CZT, which is the material detection for the SPECT systems. So let's take a look at conventional versus direct conversion detectors, where CZT is one of them. In conventional technology, basically when a gamma ray hits the crystal, there's a light generated, and then we use the photomultiply tubes basically to generate these electric signals that are translated from the light generated by the crystal. However, when we use the CZT detectors, there is a direct conversion, namely when the gamma rays hit the CZT, automatically electrical signals are generated. And this is much more efficient than going through the light, and therefore there are 60 times more photoelectrons. And these photoelectrons allow us to get a better signal, therefore less noise, and therefore we can recover the true energy of the gamma ray better as compared to conventional technology. The direct conversion detectors provide us energy resolution, which is improved as compared to sodium iodide, as just discussed. The energy resolution of a CZT is 6.3 as compared to 9.6, 9.8 for sodium iodide. Another very unique characteristic of the CZT is the fact that it is made up of small pixels, where basically each of these pixels is a separate camera. And what we can do is to register these small cameras to the collimator, which improving the overall system resolution. The spatial resolution of the CZT is therefore 2.8 as compared to 4.3 for a typical sodium iodide camera. We typically divide the benefit of CZT to three domains. One is the size, the other one is the fact that it's a pixelated detector, and the third one is the improved energy resolution. So with the size, we can really come up with optimal designs. There are a few systems in the market that are already organ dedicated, such as the heart, and the breast, and also the waist area between the detection area to the edge of the housing is also reduced when we use the CZT. The other thing is about pixelated detector, which improves the intrinsic resolution, as just discussed. And typically we say that the system resolution is made up of the intrinsic resolution and the extrinsic resolution. So with CZT and the registered collimator, we are basically eliminating that factor in the equation and thus improve the system resolution, as can see in this example here with the hand, CZT versus sodium iodide. The third piece is about energy resolution, where we can do dual isotope imaging. Here is the spectrum of the sodium iodide versus the spectrum of CZT. And you can see very nice valley here separating the iodine 123 from the technetium. And just a preclinical example for illustration with 3 isotopes of technetium, iodine 123, and thallium. And another advantage when using pixelated detector is basically when you have an angle-based camera where photon is hitting here, there are not enough multi-photo multipliers, PMTs, to make the angle calculation. You have pixelated detector where each of them is basically a separate camera. There is no need for angle calculation, and therefore the useful field of view and the central field of view are basically the same with regards to the detection performance. So as discussed, the CZT detector had different spectrum properties as compared to the sodium iodide. When we're looking at the CZT spectrum, it is much nearer as compared to the sodium iodide. Specifically, the energy resolution on the right-hand side is much improved as compared to the sodium iodide. This is what allows us to do multiple isotope imaging, and the separation between the isotope is much more feasible. So here is a phantom study for cardiac insert where myocardium is filled with technetium and iodine 123, where the defect insert is with technetium only. When we look at the image that derived with the iodine 123 window, you see that the sodium iodide depicted that image, while the defect in the CZT is much more crisp. When we're looking at the technetium window, we see that the sodium iodide and the CZT look very much the same. So again, the energy resolution and specifically the right-hand side improvement of the curve as compared to the sodium iodide is what gives us this ability to see the defect and not be spillover by the technetium into the iodine 123 window. Here's another example from the neurology space where you have the perfusion imaging and you have the DAT scan imaging with iodine 183, where the perfusion is done with technetium. Again, great separation between the two, which illustrates the benefit of CZT. Another example with parathyroid adenoma, again, iodine 123 and technetium. And what we can see nicely is that the iodine with the green one and the technetium with the reddish one, and again, a great separation between the two. Is another aspect where CZT comes to play, and quantitation these days trying to look at spectrus UV become more and more important. When looking at the count rate differences between sodium iodide and CZT, essentially with CZT, the count rate is quite linear. This is the truth, and this is the observed count rate, and you see that it's quite linear with CZT, while with sodium iodide, there is a pileup here in the saturation that does not occur in the CZT. In clinical practice, we are typically around that area when we're talking about thermognostics, such as lutetium isotope. Here is a clinical example provided by Professor Pedar, showing us the lutetium imaging with a CZT. Quite nice example of the capability of CZT to produce lutetium images. Let's shift gears from the spec domain into the PET domain and discuss PET reconstruction and the trade-off between sensitivity and image quality. So this illustration basically provides a trade-off between scan time, injected dose, sensitivity to image quality, and outlines two technologies, technology 1 and technology 2. And as we can see, the technology 1 is basically improved the image quality as we provided more data. However, technology 2 is really starting off quite quickly, but then saturate at some point. The question is, what happens in reality? Since we believe that in reality we are limited with our either scan time, injected dose, we always like to take care of the sensitivity first before we look at any other characteristic in the system. And therefore, this is a technology that we would like to move on with and ensure that we have the right sensitivity in hand. Let's look at the same thing, but from a different angle. When we have basically a certain amount of counts, let's say that we have counts that are increasing, and then we have the filtering. We have a certain amount of counts, the image is quite noisy. If we apply some filtering, we can recover some of the roads. If we apply more filtering, we can maybe recover more, but we really deteriorates with regards to the resolution. If we had more counts, therefore we can see more roads, we apply filtering, so now the image is looked a little bit less noisier, and if we apply more filtering, the image is even lesser noisier, but we sacrifice the roads that we were able to see here, for example, over here. Now, if we add some more counts into the image, we can recover all roads. If we apply some more filtering, we basically can see that there is less noise in the image, and this is the sweet spot, basically. And if we apply more filtering, we actually deteriorate the image quite substantially, and therefore we don't want to do that. So the more counts that we have is much better than anything else. And let's take another more illustrative example. So here is letter A, and let's assume this is very small pixels, infinite contrast, and we can really argue that the left image is better than the right image when it has bigger pixels. Now, if we add more realistic situation and we limit ourselves with regards to the contrast, we still can say that the left image is better than the right image. Now, if we take a more realistic situation where we add some noise into the image, now some will argue that the left image is not as good as the right image, and one may question which one we should go to, which direction. And basically, if we add some more counts to the right image, I think all of us will agree that the right image is better than the left image. Therefore, this is another example why sensitivity is the most thing that is important when we're looking at image quality. Sensitivity first, in a sense. And how is that affect? Let's move into the reconstruction domain. So we discussed sensitivity and the benefit of that. But what about reconstruction? So with reconstruction, there was a big improvement over the years, starting with filter back projection, then we move into the iterative reconstruction. Time of flight was added, point spread function modeled, and then recently with the BSREM, with the regularization algorithms, they really took it quite a step forward. So let's take a look at regularized-based reconstruction. What does it mean? Basically, if we are taking the iterative reconstruction, we do have a term of which is the likelihood term, right? We would like to maximize the data that we acquire to the resulted image that we are getting at the transaxle space. However, and we'll do it in the iterative fashion. Now, the issue with that is that if we increase the number of iterations, some noise is introduced, and the more iterations are, the more noise is introduced in the image. So here we come the regularization term that basically applied in between the iterations in order to ensure that the noise is not really getting to the level that we don't want. It basically favors such an image and avoids this type of image. And by doing that, it regularizes the image in between the iterations. And here is another example that shows what just discussed. Partially converted slices, when we're doing 2 iterations and 10 subsets, as you can see that this lesion here is not fully recovered. However, when we go to 25 iterations and 10 subsets, this lesion is indeed recovered, but the noise, as we just discussed, is increased in the image. So therefore, when we apply BSREM, we are resulting in full convergence or full recovery of the image while maintaining the image with less noise as possible. So let's see what does it mean to apply regularized-based recon as compared to regular iterative reconstruction. So here is a patient who referred for staging, a melanoma patient, and we can see clearly these lesions. However, when we applied BSREM or regularized-based recon, all of a sudden these lymph also been lighted up. So this is really can change patient management looking with improved reconstruction technique. So let's spend some time about respiratory gating and artifacts that are introduced by respiration. I don't think I'll have to convince you that these artifacts are something that if we can eliminate, all will benefit, especially in times where we really improve on the image quality of the PET-CT images. This is just a clinical example showing what happens when we correct for respiration or when we use the regular reconstruction without compensating for respiration. So obviously, there are several ways to correct for artifacts that introduced by respiration. The first thing that needs to be done is to take the PET data and break it into small dynamic frames. How long these frames is dependent on the patient, but with respiration, where the respiratory cycle is around 3 to 4 seconds, but probably with 500 milliseconds or 250 milliseconds will be fine. And then once we have the data, we can then use it either to correct in the image domain or in the frequency domain or in other domains. In this case, use the principal components, identify 3 principal components, and then see which one more resemble respirations. Once we identify this one, we can use it and then correct for respiratory motion. This is just a clinical example showing the benefit of correcting for respiratory induced motion. Here is very lesion that was identified after correction, and before correction, we can't really see anything around it. So this is really a useful tool for image diagnosis. There is obviously a lot that can be done in the domain of image reconstruction in addition to the getting quantitative results. And one of them is ultra-fast least mode reconstruction, to be able to reconstruct the data very fast. And basically here is an example of patient data that was referring to 1 second per frame. And each frame was basically reconstruction within a few hundred milliseconds. So as you can see, the patient is nodding while it's speaking, and we can detect exactly when he nodded his head. And here are the slices when motion correction is not applied. The images are okay, but they are not as sharp as when motion correction is applied. In this case, we ask the patient to move his head back and forth, and again, we can clearly see that without motion correction, the image is blurry, while following motion correction, the image is much sharper, as expected. So we'll take a closer look at what we have discussed so far. When we're working with analog detectors, we basically can see as much. When we're moving forward with digital detectors, we can see more as compared to the analog detectors. Now, when we increase the sensitivity, as discussed before, and reduce the noise, we can detect things that previously was blurred within the noise, as compared to the just digital detector without the high sensitivity. And when we apply motion correction, the blurring effect can be taken off. And then when we apply the right reconstruction, we can really recover the true SUV value regardless of the size of the lesion. I would like to discuss the last section, which is basically around artificial intelligence and deep learning. When we look at artificial intelligence or deep learning, we're basically looking at 3 main domains. One is the image generation, the second one is assisting reading, and the third one is precision medicine. Image generation is associated with image quality, workflow, standardization, segmentation enhancements, and things around that. When we speak about the system reading, we're looking at algorithms that really assist the physician to do the diagnosis, move forward with them, do it with a higher quality and faster. When we discuss precision medicine, we are trying to use the computers and the metadata that we have to enhance beyond what we can see with the data, to go through the precision medicine into treatment prediction and things around that. Few words about the traditional programming versus machine learning. So in the old ways or traditional way, we're basically took data, we know where we want to go, we had clever people thinking about defining the rules. When we are thinking about machine learning, we have the data, we know where we want to go, and now we ask the machine to find a set of rules for us. The advantage with that is that the machine can find many rules that for us it may be more difficult to do. Nevertheless, the disadvantage of using that technique is that sometimes we don't really know what happens and how these algorithms came about. So therefore, the regulatory aspect of machine learning, and especially deep learning, is much more difficult as compared to traditional programming. Artificial intelligence and deep learning can assist in many ways. As I said before, it could help in stamp preparation, operation guidance, image reconstruction, even in the image denoising, segmentation, and in the future, also, as we discussed, decision support and personalized medicine. So we already see these algorithms. We know that the rest are coming specifically around segmentation and workflow, and in the future, we'd like to move in the prediction domain. Here are some examples that currently in the marketplace for segmentation. These are lobe segmentation in addition to lung segmentation, kidney segmentation for SPECT CT, and also radiotherapy organ segmentation, which can do much more than the current techniques that are available today. I would like to wrap this session by providing two additional deep learning examples, one in the CT domain, comparing the traditional FBP or the old way of FBP, iterative reconstruction, and then now with the deep learning. As you can see that the deep learning modulated the noise much better than the other reconstructions. And here is the PET-CT study where the deep learning task was asked to denoise the image. So here is the full time, third quarter OSCM, half time OSCM, and then you can see that the noise is increasing as you reduce the statistic. And this is very reasonable. But with deep learning, we are able to recover the same information that we have in the full time. So that was my last slide. Thank you for your attention.
Gil, thank you very much. This is very enlightening, and I think that creates a lot of opportunity, a lot of challenges, and it emphasized the need for the professional in nuclear medicine to stay abreast of what's going on, and to stay very well connected and have physicists help to try to understand all this. As Andrew said, physicians sometimes have difficulty to comprehend all this, but I think you make a very complex approach to the future of nuclear medicine, very clear and very simple. I don't know if I don't see really a question yet from the audience. Gil, the question for you, I'm going to start awaiting some questions from the audience. I've been privileged to work with CZT very early on in 2020. I remember doing some research on animal with Philips. Siemens was thinking about this. I think that GE took the lead and took on the challenge. What you very early on also, I remember discussing with Aaron Perez, who was the chief engineer in IFA, about the cardiac system, and I challenged Aaron to come up with replacing the sodium iodide planar system, the dual-headed system. Where do you think that the field of and the technology of CZT is going? I'm sure that you're aware of the spectrum dynamics system, which to me is a very good alternative and enable us to have a 360-degree type of gantry, which to me is probably better than just a dual head in terms of quantitations and in terms of dynamic imaging. Can you try to elaborate a little bit on this? And I'm dreaming of a world where it would be a 360-degree CZT detector and full quantitation, and be able to do a fair amount of research work on a CZT system.
Sure. So first of all, do you hear me fine?
I think so.
Okay, great. So good morning, and really thanks for the opportunity. I guess it's still daylight at your time. As you may see in my window, we are advancing in the day. You know, what I try to do here, Dr. Urbain, in the presentation is kind of provide an outline of the three main things that I'm, you know, my sons in general, what I need to take care of on a daily basis, whether it's the spect, PET, and the digital. And each of them, I try to look at the different topics which I think are most advancing. With the CZT, we do see the new technologies that come up. We strongly, as you may you know, we are heavily invested in CZT. I mean, we're making our own CZT. We do have the factory that does it, and we've been in this CZT business for quite some time. Our cardiac camera came out 2009, then the breast imaging, etc. The nice thing about it from engineering perspective, and I always use, if I had to select one slide in my presentation, is the one that, and unfortunately the laser pointer, I've seen that that was missed in the conversion, I guess, of the video. But what I'm always trying to look is, you know, what is it in the CZT that is beneficial, and really this whole size of it allow us as engineers to come up with very unique designs to come as close as possible to the organ, which is, this is one of the, you know, toughest things to do. And when you look at different geometries that you mentioned, we're basically getting closer to the body. We are managing to take the big detectors and, you know, break them down to pieces. This is what we have done in the cardiac, both ourselves and under vendors, basically. And the closer you get, it's better. Though the number of CZT that you can put in this geometry, the number of CZT, or what I typically call the horsepower that you can put around these systems is limited as compared to the dual detector sometimes. So it's you know, pros and cons with that regards. It's almost you know, 1/3 when you think about it when comparing dual head detectors. So we carefully looking at all this technology and how to maximize the potential. We truly believe that we, you know, with the energy resolution that is brought with the CZT and the direct conversion and the small size and the enabling on dual isotope, this is the way to go. We are pushing very hard in that direction. You know, that we basically move forward not only to limit to the low energy, but now we also supporting the medium energy, you know, for indium and things like that, the 240, 245 keV as well, because we believe that this is very important part of nuclear medicine that we need to cover and we can't neglect it. So therefore, this is very important. Moving from planar to spec, this is my dream for many years. Sometimes I tell to my, you know, kind of bring you guys into the engineering base. I tell to my guys, you know, with our next system, we're just going to eliminate all planar images. It's just going to be so provocative, and let's see what the community will tell about it. But then I think it was somewhat our fault. I mean, the industry and the community, because while in PET we immediately move into the 3D. I mean, there's no 2D there. With spec, we kind of gradually, you know, moved on, and we let ourselves. We weren't as I would say bold to say, you know, this is a 3D system. I mean, spect is available. There are a few papers. I mean, and the literature is full of evidence. The spect is better than planar. But then we always provided spect in addition. It's almost like attenuation correction. You know, when we came up with attenuation correction, we said, well, you know, let's give the unattenuation correction, the uncorrected, and the corrected. You know, kind of give the physicians the ability to move back. So everything moves slower than expected. And sometimes maybe we need to be, you know, bold and proactive. But we need to be careful not to go too fast at times, because there are lots of evidence and clinical evidence with planar imaging in many, you know, indications such as renal, such as lungs, such, you know, as brain, like HIDAS images, you know, the bread and butter. That we need to ensure that we cover that as well. So you have the tools, you know, to report to your referral physicians at the end of the day. So we won't come short with that as well. But definitely, this is the material that we feel that we should move on with. I mean, it's much better than the sodium iodide with regards to the energy resolution. I think we still have a long way to go to optimize it and make it even better. As it, I mean, compared to what we are now. I think in a few years' time, images will look, you know, much better as compared to today.
Thanks, Gil. I fully agree with you. We are moving in our own lab. We are moving from 2D to 3D using the advantage of CZT 360 degree. I have a few questions for you. First question is from out West Canada, from my friend Phil Cohen. You probably, I'm sure you're aware of United Imaging in China. The trend now is to go full body imaging in pets. Phil Cohen is asking, Dr. Cohen is asking, when can we expect a full digital PET detector similar to CZT on the market? So in other words, if I understand Phil correctly, he's asking, when can we expect a full body spec CT with CZT detectors?
You know, it's all about you know, efficiency and the community be able to adapt it. We had a nice experiment in 2010, actually. We came up with a CZT system, with a cardiac system. I don't know if many in the audience know that, but we came with a system that can do very fast cardiac scans, like in 3 and 5 minutes. And we thought, wow, that's a revolution. So let's put a high-end CT to it. With the 64 slices at this time, the system was what's called the 570, and we say, wow, that's the, you know, one-stop shop, right? I mean, it's a fast nuclear, it's a fast CT. That's the way to go. We were so, you know, engineers are so fascinated by the technology. We moved fast with that, and we put it in the market. And unfortunately, you know, within a few years, we had to take it off our menu because the market was not ready for that. I mean, the price was too high for the value, and you know, with all the enthusiasm that we had as engineers, because we felt that's the right thing to do, it was just the selling point was such versus the value was such that it just didn't make it. So that was a good lesson for us as well. And every time I get, you know, to think about it, I say, what is the sweet spot? I mean, where do we want to go? I think now with the PET systems, there are, you know, we have the 3, 4, 5 rings. The competition also had these kind of things. I mean, obviously, we, as you saw in the presentation, we focus as much as we can on sensitivity. I mean, we first feel that we need to have the counts in order to get in the adequate image and the robustness. And now the question is, and you may have seen in the S&M that we move with an additional 5 centimeter, the 6 ring ready. So we are now in the 30 centimeter. And when we look at it, the sensitivity is increasing dramatically. Now we're asking ourselves, working with you, basically, what would be the sweet spot? I mean, now we're going to go into 30, 40 seconds per field of view. We're going to be done a whole body within, I don't know, 3 minutes, okay? Now, the question, and with a reasonable price, right? So, I mean, it's still reasonable. I mean, we didn't move to, doubling that or tripling that. And the question is really, what would be the sweet spot? Because from technology perspective, we can put as many rings. I mean, even in the spec, I mean, we can make the columns as big as we want. I mean, there is no limitation today to that. I mean, spec is a bit different because we want to make sure we are close as possible to the body, right? So if we have the belly or we have other organs and we have a very long axial field of view CZT or any detector, then we are limited by that. So we really want to keep to be as close as possible, but it's very feasible. The question is, what is needed? Where is the sweet spot? What is more efficient? I mean, I remember with the cardiac system, when we moved from 15 minutes to 3 minutes, there are a few laboratories that what they changed the number of changing rooms, right? Because that was the bottleneck. People coming on and off the table, I mean, it took more time than the scanning itself. So they added some changing room for the patient. So I don't have an answer for that. When it's going to come, I just know that we really need to, as much as we're fascinated with the technology, we really need to look at the sweet spot of and make sure that technology can be embraced by the community.
Thanks, Gil. I have a subsequent question to that, but I want to also share with you another question from Jean-Marc from Quebec, who has a very interesting question. Learning, and it's related to AI. So Jean-Marc, the question is, when do you expect deep learning implementation in clinical practice? It's a key question for the future.
Yeah. So as I said, when we think about deep learning, we separate it into 3 main domains. Is the workflow, the segmentation to do things better than are today. I think your question is more oriented when the AI and the deep learning will assist in the reading, and then so that's the second part. And the third one, we really look at beyond physician, to put so much information in there and go into the prediction. For example, here is a PET-CT study. Which patients will basically benefit from the lutetium treatment that we just discussed? Because we know that it's not work for everybody, and it's very challenging to know which patient to send for the treatment and which one of not. And I think you have seen that in many cases, some are doing very well and some are not. So if I focus on the first one is already been taken care of. I mean, we already put in the market. So far, I try to be not as commercial as possible, but just it's ourselves and others. Let's put it this way. So I'll try to be as unbiased as possible. Already put some tools in the market for segmentation, for workflow, and as I show you an example for image generation to improve the image generation. I've seen very nice work, and I can share that we work very strongly on going with the physician assistant tools. The key here is data, as much data as possible. I can give you an example. When we trained our the engine and we provided it cases which has only 1 and 2 lesions, okay? And then we tested with cases where there are 5 to 6 lesions.
the amount of radioactive material that we inject. And his basically his question essentially is related to the fact that how do we balance out the decrease of radioactive material that the industry is telling us that we can do with while not using basically quality, sensitivity, specificity of the images for disease management.
Okay, so yeah, that's a good topic as well. I agree. It's a good question. Basically what we are doing is testing our algorithms on very few setups, right? We don't have all the setups that we can imagine in the lab. So every time that we are reducing the acquisition time, or we are selling or promoting time reduction or dose reduction, we are testing that in certain conditions. Now, what I found out is that the variety between different labs could be very extreme. I can tell you that when we have physicians coming to read some of the patients, say, which one do you like? I mean, what flavor do you like of that image? I'm very surprised to see the variations. So therefore, it's difficult for me or for us to say exactly, how much, I always call it salt and pepper, how much that kind of things we should put in our reconstruction in order to make it adequate for everybody. Nevertheless, and I don't know if that directly address your question, but nevertheless, with the BSREM reconstruction, what we are trying to do, and with the deep learning as well, is to take some of these variations away of the equations and provide as consistent as possible, images without you or your physicists need to fine-tune these images according to your needs.
Gil, we have 2 minutes left. I'm going to take the liberty to ask you the last questions, and it should be pretty much a quick answer. My understanding of CZT is that it's not that easy to optimize it for the energy of the photons. So one of my questions to Aaron Perez a few years back was that, well, why don't you use CZT for 511, and if you can modulate the CZT detections to the energy specific energy window, maybe we can do spect and PET on the same machine.
Yeah, I mean and I know that you discussed that with Aaron, and we also have much discussion around it. It all depends on the efficiency, right? We need to see to ensure that the efficiency, the thickness of the CZT is such that is effective to do the job. One thing that you have to, we all need to keep in mind that while in PET we have the the positron advantage, and we don't have the collimators, right? So our sensitivity is much increased, and we need to ensure that the CZT can do the same thing from saturation perspective. There isn't much of an issue. As you saw, there is a very nice linear correlation between the activity and the measure. I mean, CZT is great with that regards. It depends on the efficiency of the crystal to be able to ensure that we capture as much as possible as needed for PET.
Thanks, Gil. It's 10:45, so we're just on time. I'm going to take the approach of the media, what I see on TV. Don't go anywhere. We will basically have a short break, and we'll reconvene in about 15 minutes. We'll have the privilege to introduce to you the future of nuclear medicine in terms of physicians. In terms of physicians taking basically the torch and carrying the torch of the passion for nuclear medicine. Thank you very much. We'll see you in about 15 minutes. Nicola, I don't know if you have any type of announcement during this coffee break or Diet Coke or Diet Pepsi break?
No, just enjoy the break, and we'll see each other in 15 minutes.
Thank you very much, Gil. Thank you very much.
Thank you. Bye-bye. Great seeing you. Bye.
Bye. Well, welcome back, everybody. It's 11 o'clock, so in order to keep up with the schedule, I'd like to introduce Dr. Jennifer Schroeder. I've been very privileged in life to meet a very bright mind, dedicated and great physician. About 2 years ago, 2.5 years ago, I came to Wake Forest to build up the diagnostic program at the request of the chair of radiology. And as soon as I came on board, I got contacted by the other nuclear medicine physician stating that we have a very bright radiologist resident who is very interested. She's passionate about nuclear medicine. We need to get her on board. And at the time, unfortunately, we didn't have a position. But we were somewhat lucky that at one point in time a position open. And what I learned is that that very bright radiology resident was so passionate that she decided to go and train in the Mecca, one of the Mecca of nuclear medicine in the United States, which is the University of Pennsylvania. So I remember calling her about a year and a half ago in July of 2019 and asking her if she would eventually consider to come back to Wake Forest. And I learned that her passion was not only education, and she had done a lot of work in education, but also diagnostic. So it's my really privilege to introduce to you Jennifer Schroeder. She joined us this past August, and she's the new generation of mostly dedicated, passionate nuclear medicine physicians. She cares extremely well about patients, so it's my honor to introduce Jennifer. She's going to talk to you about Lutathera and the primer. Jennifer, the floor is yours.
Thank you so much, Dr. Urbain. Can everybody hear me? I'm just going to share my screen here. All right, can everyone see? Again, thank you so much. Oh, can you hear me?
Yeah, that looks good, Jennifer. I think we can hear you. We can see your slides.
All right. Well, thank you so much, Dr. Urbain, for that wonderful presentation. I am very excited to be here and to get to share with you what I know and what I have learned about Lutathera. I have a lot of information, so I'll just jump right in. I do not have any disclosures or any financial interests in any of the material that I'll be talking about today. And some of our objectives are to talk briefly about neuroendocrine tumors, to talk about their newest directed agent, which is Lutathera, to talk about its indications, contraindications, expectations, pre-therapy evaluation, a therapy protocol, and then some toxicities. I also want to talk about some pearls and pitfalls from our early experiences. And really, this presentation I've created as a reference point for you for future practice. Like I said, there's a lot of information in here, and I'm going to go through it pretty fast. So I hope you all have had some coffee. But hopefully this is something that you can access later to go back when you're working with patients and treating them with Lutathera. So what is a neuroendocrine tumor? It's a very rare neuroplasm that arises from neuroendocrine cell lines. Back in the 1970s was very rare, 1 out of every 100,000 patients for incidence. So why do we care if it's such a rare tumor? Well, neuroendocrines of all stages are on the rise, and it's over more than doubled. It's now 6 times what it was in the 1970s. And that's not just for early stage. You think maybe we're discovering them earlier, and that's why it seems like incidence is increasing, and that's not necessarily true. It really, all stages of neuroendocrine tumor seem to be increasing in incidence. So even though still considered a rare tumor with only about 6 to 7 patients out of 100,000 for incidence, we're starting to see them at more rural, smaller hospitals and not just the large academic meccas. And where do neuroendocrine tumors usually arise? Most commonly, they arise in bowel. Depending on the geographic location, can depend on whether it's small or large bowel. And then the second most common site is the pancreas. You've got some other areas that it will show up in the chest, in the lungs, but most primarily in the abdomen. And then the average age for your neuroendocrine tumor patient that you're going to be seeing is around the age of 60. That's the biggest peak. Although your younger patients that are presenting in their 20s, 30s, and 40s oftentimes will have inherited risk factors, most commonly MIN1 or MIN2 and von Hippel-Lindau, but there are a few others you can see here that also have some correlation with neuroendocrine tumors. Treatment options for these patients. So patients who have, tumors that are grade 3 or higher, up to 80% of them will present after metastasis. So surgery is really the only chance for a cure for these patients, but it's really not an option for most patients. Usually they've had symptoms for many years before their disease is discovered. And so most of them aren't candidates for surgical treatment. And really the majority of them fall into systemic treatments. And the mainstay of that is somatostatin analogs, which basically universally our patients are on here that we see, though they've progressed through it. There are a few other agents that are available that are sort of newer in the market, like everolimus and sunitinib. They're not new agents, but they're new for the treatment of neuroendocrine tumor. There's also high activity indium-111 octreotide, which actually I have never had experience in. I didn't know much about before putting together this lecture, but now we're talking about lutetium-177 dotatate, also known as Lutathera. But don't get confused, sometimes it's also called PRRT, which stands for peptide receptor radionucleotide therapy. So if you see other physicians refer to it as that, it's sort of considered interchangeable with this Lutathera. So what is Lutathera? It is a radiolabeled somatostatin analog, which is used in the treatment of receptor-positive gastroenteropancreatic neuroendocrine tumors. And it was approved in 2019, at least in the United States, by the FDA based off of the pivotal NETTER-1 trial, which was a phase 3 randomized controlled trial at multi-center. And what were the results that led to this approval? Really, it showed that when you're talking about patients who were in the Lutathera arm, had significant delay in progression compared to the control arm, where the control arm was just on somatostatin analogs and the Lutathera arm was on somatostatin and Lutathera, and also showed an overall survival benefit. Both of those were statistically significant. As far as breakdown, it was very well stratified as far as male, female, grading of tumor between the two groups, and about 100 in each arm. And it showed that the total number of patients who demonstrated response by imaging criteria was 18%, which you say that sounds like a pretty low percent for response. But when we're comparing to other systemic agents that are available for these patients, the other agents really don't have a response rate greater than 5%. So this actually is a huge breakthrough for this disease as far as therapy goes. And here just reiterate the outcomes of the NETTER-1 trial. So why lutetium-177? It is a emitter, predominantly emits beta, which is good for therapy, but also has a little bit of gamma and X-ray. So if you needed to image it, you could and see its biodistribution. The half-life is also optimal for therapy with half-life of 6.7 days. So hanging around long enough to have effect, but not too long to cause lots of toxicities. And the tissue penetration is about 2.2 millimeters. So not a long tissue penetration. You're not worried about irradiating too many normal tissues. The cases where maybe I'd be a little more concerned is if it was a patient who has miliary disease, either of the lungs or of the liver, where you're getting, because of the high number of tumors, you're getting a large volume of otherwise normal liver or lung tissue being exposed to that radiation dose. Those types of tumors aren't that common though. So how do you choose a patient for Lutathera, or which patients that are coming to you should be candidates for Lutathera, I should say, because as a nuclear physician, I don't go out and find my patients. They usually find us through their oncologists. So we're looking at patients who have inoperable disease, which again is the majority of patients, that they have progressive disease on their mainstay therapies, on their somatostatin analogs, and they continue to progress through. We're looking at patients who have low-grade tumors, so grade 1, grade 2, which by pathology would be correlating with a Ki-67 index below 20. Anything above that, and they tend to respond less well. So some of these patients have had these tumors for decades because they're very slowly progressing, and they don't have pathology from their primary tumor. And so in that case, when you don't have their Ki-67 index to refer to, any patient that has somatostatin receptor positive disease or is positive on dotatate PET, they are also candidates. Although noting that on the NETTER trial, NETTER-1 trial, it showed that increased expression or max SUV uptake on dotatate PET did not necessarily portend a better response to therapy. There really are no absolute contraindications per the NETTER-1 trial, although I would throw out there that there are relative contraindications such as active intracranial disease. Again, that's very rare. And being a little more cautious in patients who have poor renal function, and we'll get into why. So when looking at patients or prepping for therapy, I always get a set of pre-therapy labs. I'm looking at their blood marrow function, looking at their renal function, and looking at their liver function. I especially pay attention to patients' liver function if they have a large tumor burden or have had prior liver-directed therapies, so embolizations, radioembolizations, chemoembolizations. And then looking at their pre-therapy imaging, what do I want to know from that? I really want to know, am I convinced that this patient has progressive disease, or is this maybe something that's a little more subtle, and maybe following them up might do them more good than jumping the gun. Also, I want to know what's the distribution of their disease. Do they have a high volume of liver tumors? Do they have a lot of bone metastases? And then what is their overall tumor burden? Is it small or is it large? Is it 5 tumors throughout their bodies? I would consider that a small tumor burden, all of them being less than 2 centimeters. Or is it large? Do they have 50 plus metastases? Those are the things that I'm looking for when looking at their pre-therapy imaging. And then prior to therapy, we always do a patient consultation where I sit down and talk with the patients because it's a very long, complicated process. Therapy can be 8 to 10 months if you're including follow-up. And you'll be seeing these patients a lot. So getting to know them ahead of time, I think, is important. I really want to know when I talk to them, what is their disease and treatment history? How long have they had it? What other treatments have they had? External beam radiation or other directed liver therapies? What's their symptomatology? Are they symptomatic from their disease, or do they live as if they are cancer-free? What's their functional status, and what are their goals going forward? And we talk about patients' eligibility for therapy. Currently, Lutathera is approved for patients with progressive disease. That may be changing in the future, but really, I try to talk to patients about, not jumping the gun, because this is a good tool, but it will be here when they need it, and they don't necessarily need it right away, especially if they're doing well, otherwise asymptomatic. I would hate to make them symptomatic from their disease or decrease their quality of life for 10 months while I'm treating them if they're otherwise living a normal life. And then what are their expectations? I talk about NITR-1 trial results, you know, that 18% of patients responded, and that there was a significant change in progression-free survival. And we also talk about radiation safety protocol. What's their home setup like? You know, is this something that's going to be feasible for them? Or are they going to have to make arrangements for other family members or other members that they care for? And then what's the risks of this procedure and what could be the potential benefits? We talk about that when we go over the consent process. So I just wanted to put this in here so you have a reference. This is a sheet that we give our patients on the radiation safety after their therapy. Basically, the basics are, you know, time and distance. And basically for 5 days, we're having them, you know, not sharing food and drink, not preparing food, no physical contact, and keeping at least 6 feet of distance. And the dosing regimen for their therapy is 4 doses of 200 millicuries given every 8 weeks, with a total therapy time of 8 to 10 months. I put that 10 months in there because we follow the patients up 2 months after their last therapy. So it is crucial to plan these therapies around their somatostatin analogs. They can stay on those analogs, even though patients, by the time they present to us, are progressing through. It's still thought to be beneficial to keep them on it because even though it's not preventing progression, it's probably still allowing some amount of control of their disease. And so we keep our patients on their somatostatin analogs. We just schedule around it where we give up to about 30 days distance from their last shot, because most of them are long acting, before we give them their Lutathera infusion. If they were on short acting, you'd only have to wait about 24 hours. And then I put this last line in here, insurance coverage. At least in the United States, it's a very expensive therapy for patients, and I know very few patients that can financially afford it on their own. But we have a very great department that helps us with pre-authorization and getting these patients covered so that they can get the therapy that they need. So the day before therapy in reproductive age females, we have to have a negative pregnancy test within 24 hours, or they have to have been without a period for 1 year. I also recommend patients have a good fluid intake the day before. And on the day of treatment, we have them be nothing by mouth for 4 hours beforehand, and we always pre-treat with an antiemetic. Our antiemetic of choice is Zofran. And we give them 2 IVs. So the first IV is for amino acid infusion, which we begin 30 minutes before we begin the Lutathera infusion. And this is to continue throughout their Lutathera administration and for 3 hours after. No matter what you do with the Lutathera dose, if for whatever reason you have to decrease the dose of Lutathera, you never decrease the dose of amino acid infusion. And we'll go into what is the purpose of that amino acid infusion and why it's important. And then Lutathera, you start 30 minutes after the amino acids and you infuse for 30 minutes. We have our patients set up in a private room with a private bathroom for radiation safety reasons. And there's other prep that goes on depending on the institution for radiation safety. Some institutions like to cover their bathrooms in saran wrap or in other protective adhesives. That way, just to make cleanup a little easier. So metabolism, right after infusion, the peak plasma concentration is seen. About 43% is protein bound. And by 4 hours after the start of infusion, you can see that normal biodistribution that you would expect to see, like you see on the dotatate PET, so kidneys, liver, spleen, and patient's tumors. This is a myth of one of our patients who, during the middle of infusion of her Lutathera, she said, oh, by the way, I've already stopped to go get my somatostatin shot this morning. And so in order to reassure us that the Lutathera distributed appropriately, we put her in our scanner to take a picture. As far as hepatic metabolism, there is no significant hepatic metabolism of Lutathera. The Lutathera is primarily eliminated from the body through the urine, which is why I watch their renal function, and I'm always wary in patients who have borderline or low renal function. This therapy is not studied in patients who have severe renal dysfunction or end-stage renal disease, although there's at least one case report out there showing a successful Lutathera therapy in a patient on hemodialysis. And I've included that link here if you'd like to go back and look at that, if you ever run across a case where that may be a choice. And the effective elimination from the body through the urine results in about 65% being eliminated by 48 hours and greater than 99% being eliminated by 14 days. I put this picture of the plane up here to remind myself that, even though these patients have greater than 99% eliminated by 14 days, these patients require travel cards during their therapy and for 3 months afterwards, because if they cross the border, they could be setting off radiation detectors that are set up there for national security. And based off of papers I've read, it seems that the border detection, while very sensitive, is not very specific, and the Lutathera can appear to have a similar signature as plutonium. So as you can imagine, that leads to very long delays in travel for our patients. And I have had several patients who have told me that even having the travel cards, they've been detained for hours in both directions because of this therapy. And then I go in to talk to the patients about warnings and precautions. Basically, this is the setup that I have for my informed consent, talking to patients about what to expect. And I always separate it into 3 categories: acute, subacute, and chronic. All of the toxicity profiles are taken from the National Cancer Institute toxicity criteria. So we'll just go through those. So acute, most common acute side effect patients experience with nausea and vomiting. You can see here from the NETTER-1 trial that up to 60% of patients were nauseated, which is why we pre-treat with Zofran, because there's nothing that a radiation safety officer likes less than a radioactive and nauseated patient. This nausea is really more attributed to the amino acid infusion than it is to the Lutathera. So if you're changing formulations, you may notice that the number of patients who are getting nauseated may change. Regardless, we pre-treat with antiemetics. And then about 30% of patients in NETTER-1 had increase in their abdominal pain after their therapy, for which they were treated with oral medications, their oral pain meds that they were already on. And then patients experience some diarrhea and distensions. You can imagine having a neuroendocrine tumor puts it at an increased risk for that. Another acute toxicity that can happen, which is much less common than all the other ones we've talked about, is a hormonal crisis. From this paper here, out of 479 patients, only 6 patients went on to have acute hormonal crisis that was severe enough to require hospitalization. You can see the breakdown of their primary tumors. The takeaway, I think, from this is that all patients who had a hormonal crisis, though it was very rare, had certain things in common, and that was patients who had a very large tumor burden. They all had liver metastases. You can see these over here on the side are the pictures, NIPS from these patients. And they all had pre-existing clinically overt symptoms from their disease. So if you've got a patient that fits all that criteria, maybe being a little more alert when you're treating them. So what constitutes a hormonal crisis? The crisis could happen anywhere from immediately after infusion through 48 hours. So at least that's the time frame for these 6 patients. Most common symptoms included flushing, diarrhea, hypotension, and bronchospasm. So pretty standard neuroendocrine tumor type symptoms. But additional severe symptoms included metabolic acidosis and even cardiac ischemia in one case. And in 2 out of these 6 patients, they could actually measure increased blood and urine hormones. So that was sort of what was attributed to their hormonal crisis. But as far as recurrences of hormonal crises, only 2 out of the original 6 patients went on to have another hormonal crisis in their second therapy. So about 1/3 of those patients, but no patients who did not have a hormonal crisis on the first therapy went on to have a crisis after initial therapy. So if you go through that first therapy, a patient is smooth sailing, they're not having hypotension, bronchospasm, or any of those symptoms, then you can expect not to have problems with it going forward. Therapy for these patients is really supportive. It's high-dose octreotide, IV fluids, and correction of any electrolyte imbalances. I think the most common electrolyte imbalance was potassium imbalance. And then some patients got corticosteroids and antiemetics. What is the etiology? We're really not sure. You know, those two patients who had increase in their hormones that were measured, you know, was it tumor lysis, or was it that we're giving them amino acid infusion, which is a substrate for their hormone production? Maybe. But those patients that had the hormone crisis immediately after infusion, you wouldn't expect that to be tumor lysis, because it takes much longer than just an hour or two for the radiation therapy to have effect. So it may be a combination of things, and maybe partially emotional stress. We're not sure. There's still ongoing research. So other things that I warn patients about is renal toxicity. This is in there because in early trials there was damage to the kidneys, but that was really resolved after amino acid infusion was begun as a part of therapy, because this amino acid infusion helps to wash the radiotracer out of the kidneys, and it reduces the radiation to the kidneys by 47%. So again, I advise patients to stay well hydrated, but I'm really not worried about that as being a toxicity now that we're doing amino acid infusion. And in fact, recent literature shows that less than 0.005% of patients go on to need dialysis after Lutathera as a result of treatment, so exceedingly rare. And a lot of patients, as far as subacute toxicities go, express that they have fatigue. And I tell patients that this is going to peak about 1 week after treatment, and it can be cumulative. So it seems a little bit worse after every therapy, but after the last therapy will eventually resolve. Another subacute toxicity is hepatic toxicity, which is seen in less than 1% of patients. In fact, it was not mentioned in the NETTER-1 trial because it was such a small percentage of patients that experienced it. But in the Erasmus trial, which was a phase 1 and phase 2 trial looking for efficacy and safety in 1,200 patients, it did show that 1% of patients did have some extent of hepatic toxicity, including tumor hemorrhage, edema, or necrosis. I think that patients who have high tumor burden in their liver are at increased risk for this. And so just monitoring their liver function tests throughout therapy. When I was studying Lutathera for the first time, you know, somehow in my mind I fixed this idea that patients who have liver-directed therapies previously, specifically radiotherapies, or have had, you know, prior large liver resections, are at increased risk for liver toxicity. That makes sense to me, although I went looking for papers on that and I couldn't find any scientific data to support that. I'm still cautious when treating patients with these types of histories or a large liver tumor burden. And then the most common subacute toxicity that patients experience after this therapy was myelosuppression. And so we monitor all of their laboratory values before and during the course of therapy. There's very specific criteria that I've put here for pre and intertherapy levels. I also warn all of my patients to be on the lookout for fevers, chills, bleeding, and bruising, any of the signs of cytopenias, you know, because they're my most important lookout. And as far as if these patients go on to experience myelosuppression, if it's greater than a grade 2, so grade 3 or grade 4, then you must postpone their therapy until their labs recover and administer their next dose at half or 100 millicuries. If that reduced dose the next time they get therapy does not result in a grade 2 toxicity or more, then on the next dose you can resume 200 millicuries if they haven't already finished their therapy. But you must discontinue therapy indefinitely if they have a greater than grade 2 toxicity a second time, or if their toxicity results in a delay in treatment greater than 16 weeks because their laboratory values do not recover. In the NETTER-1 trial, about 8% of patients, or a little less than 8% of patients, required dose reductions due to myelosuppression. So it was a very common side effect. Very few had toxicities greater than 2. And then other subacute side effects or toxicities that patient had were decreased appetite, headache, dizziness, and alopecia. it's actually, you know, about 1 in 20 or 1 in 10 patients will come in and tell me that they've had these. So then we talk about long-term risks. This is a more difficult conversation to have with patients because it's a little less clear, or can seem less clear and scarier for patients. So secondary cancers are not necessarily isolated to just radiotherapies, but also seen in any cytotoxic chemotherapies, and I stress that with patients. But that there is a real risk of going on to develop a myelodysplastic syndrome or acute leukemia. And in all the research that has been done on Lutathera, it's anywhere between 1 to 3% of patients who go on to develop these secondary cancers, with the mean time to development being 2 and 4.5 years, respectively. And there's no cases of solid tumors yet, but this is still a new therapy. So about 10% of your patients are going to be under the age of 40 at diagnosis. And so these are the patients that I really want to talk to about infertility and other reproductive issues that come with this therapy. So the doses that we're giving are high enough, and the data is based off of external beam radiation, but are high enough to cause either temporary or permanent infertility. So if you're treating a young female who may go on to want to have children, this is, you know, a big topic that we have to cover. Also, there's risk to fetus, and so we recommend, or we have to have a negative pregnancy test prior to therapy, which we've already talked about. And we also recommend contraceptive therapy after treatment for both men and women. There's a statement about lactation that breastfeeding is not recommended while receiving this therapy. I never understand why they have that comment in there, because if we can't do it in a pregnant woman, and someone is not going to spontaneously start lactating after they finish the therapy. But again, breastfeeding is not recommended, and they advise not to begin before 2.5 months after the last dose. As far as follow-up imaging, we don't get any interim imaging on our patients during that 10-month course of treatment. We follow them 4 to 8 weeks after their last therapy, unless they have a clinical change in their status. And one of the reasons is if you do imaging earlier, you need to be aware that there may be pseudoprogression, which is, you know, the apparent imaging appearance of progression, which is really related to treatment changes. There's really no solid data on pseudoprogression, but I've collected some information here on what was sort of put out there as an expert consensus on pseudoprogression, and that is that, you know, extraosseous lesions that appear to be increasing in size but have decreasing dotatate avidity may represent pseudoprogression, and that, you know, always correlating with changes in blood and urine biochemical markers. So if you looks like the tumors are getting bigger, but markers are going down, that suggests pseudoprogression. And so if this is what you're seeing in imaging, and there's really no immediate crisis of management for these patients, they recommend doing an additional follow-up in 8 to 12 weeks. You know, these are slow-growing tumors, and you may not expect to see it to get any bigger in that time, but if it really is pseudoprogression, you may expect it to stay stable or get less or smaller. RECIST criteria is something that's used in general oncology for evaluating progression of tumors. I think that that's really difficult in neuroendocrine because most systemic therapies for neuroendocrine tumors tend to stabilize disease rather than shrink the tumor. As you can see here, the RECIST criteria, it talks about a 20% change in size or sum of the size, which, you know, neuroendocrine tumors don't change that much in a short period of time. Usually, even after therapy, you're more likely to see a difference in change of the appearance and the contrast enhancement rather than a decrease in size. And so, you know, papers that I've read sort of recommend alternating MRI with dotatate being the most sensitive protocol for following a patient, a neuroendocrine patient, through the course of their disease history. MRI has great anatomic detail and has a lot of information about tumor viability. It's shown to be the most accurate for liver and bone metastases. But if a patient can't get an MRI, then contrast enhanced CT would be the second option. And then dotatate PET CT would be the other study that I think is really useful and important in these patients, because dotatate PET CT is really highly sensitive for well-differentiated but sub-centimeter tumors. You know, that 3 millimeter deposit in the peritoneum that's going to get missed on contrast enhanced or MRI, CT or MRI. And that dotatate is really the most accurate for lymph nodes and lung lesions. We don't use FDG PET often in this patient population, but it would be something to be considered if on anatomic imaging it appears like there's a rapid progression and your dotatate PET seems totally negative. That may suggest that your patient the tumor has dedifferentiated. So here's a case example. We have a 78-year-old male who has metastatic small bowel neuroendocrine tumor. You can see his MIP here of his pre-treatment dotatate PET. He was diagnosed 7 years prior to consultation with us after he presented with scrotal discomfort and abnormal testicular ultrasound and elevated chromogranin A. He's only previously been treated with octreotide prior to coming to see us for Lutathera therapy and was progressing at the time of referral. He went through all of his therapy, successfully completed all 4 doses, and he had no toxicities greater than grade 2. So here's his pre-therapy versus post-therapy image, and you can see this dominant liver tumor here has got much less dotatate uptake and viable tumor. You can even see some of his retroperitoneal implants have disappeared in the interim. And comparing some anatomic imaging on him, here's his pre-treatment. This is that dominant liver mass. You see lots of viable tumor along the periphery, some central necrosis. And then post-therapy, even though this tumor looks much bigger anatomically, you can see that that viable tumor rim is very thin now. And with all of his other lesions getting smaller or disappearing, we're comparing these images, which are over a year apart. I think this was a win for him because previously, prior to therapy, he was progressing, and now he's stable or getting better. So something to think about for the imagers, if you are an imager as well as a nuclear physician, or something to talk about your imagers with. That these tumors have very long histories. Really want to compare very remote priors to more recent priors and pre-therapy priors, because they grow so slowly. If you're doing 6-month interval imaging, they may not appear to change between each 6 months because maybe it's 1 millimeter, maybe it's 2. But if you're looking over 3 or 4 years, I can see there's really been a 6 millimeter change between these 2 images. But also to be careful is not overcalling small changes as significant, because you do have that inter-reader variability and inter-scan variability, which I think is especially tricky when you're comparing across modalities, which inevitably these patients have a lot of different modalities that follow them throughout their history. I think it's most problematic on CT because of contrast bolus timing can make the tumors appear a little different in size, but just to be aware of that. So what are the takeaways for Lutathera? I think, that this is a great new therapy for our patients. It's really just one tool in our kit for patients with metastatic neuroendocrine tumors, and hopefully, we'll just be building on this toolkit as we go forward with molecular imaging and therapies. And for these patients, especially when they come see me very early right now, I say, it's not a matter of if you need this therapy. It's probably going to be a matter of when, because these tumors have such long histories, and we're always going to be here to treat you when you're ready for it. And as far as future research opportunities, I'd really like to see more research on sequencing of therapies, because we don't really have any data on what's really the most optimal way to sequence these therapies for the patients. Currently, we're seeing patients when they're progressing on their therapies, but what if we were treating them earlier? Would we have better outcomes? I don't know. That's something we can look at. And then what is repeat therapy outcomes? There are a few papers out there showing patients who have repeat Lutathera therapies, and it'd be something that we can look more at. And again, outcomes after treatment of early stage disease. So here, and that is it for me, and here are some of my references.
Thank you very much, Jennifer. I hope everybody appreciates your knowledge and the depth of your presentations. Before I ask you the first questions that one of the attendees asked, I want to mention that Dr. Schroeder is also, as I said, passionate and, in my view, an expert in education. So if you need to know a little bit more about the way the field is evolving and being taught, She will be giving a lecture at the International Atomic Energy Agency at the end of this month, and then she will be giving another lecture at the Society of Nuclear Medicine India early December. And I'm sure that she'll be more than happy to help you out if you send her an email or if you give her a call about the way to proceed with your program. Jennifer, there is a question from Louis Laflamme from Quebec. I believe he practices in Montreal. And the question is, in your experience, what is the percentage of patients who need transfusion support during the course of the treatment? And he's essentially talking about platelets and white blood cell.
Well, so I'm going to tell you that I just recently graduated from my fellowship. So I've only been a practicing attending for about 3-4 months now. So I'm not sure I've put a whole lot of weight in my personal experience, because the number of patients that we treat on a regular basis with Lutathera is about, I'd say, up to 3 patients a week. And I'm not always the physician that's there treating the patient. So I have yet to see a patient in my time as an attending that requires a transfusion, though I know that the data suggests that up to 20% of patients go on to need some supportive therapy, but that included transfusions and colony stimulating factors.
Yeah, thanks, Jennifer. We started our program in September of 2018. There are 2 aspects in terms of the transfusion. The number that we have is about, I would say, 10 to 15%. However, you have two aspects. The first one is you might need transfusion because of the toxicity of Lutathera, or you might need transfusion because the patient has been bleeding for whatever reason. So we recently had the patient who was readmitted over and over again, and she had angiodysplasia of the colon. Initially, she refused a colectomy. She was readmitted actually as late as yesterday, and she will have this time, I think that there'll be no escape, that she will have a colectomy. So I would say anywhere from 10 to 20%, as Jennifer mentioned. Our experience is 10 to 15%, but you really have to establish the difference between the transfusion needed because of the toxicity of Lutathera that Jennifer mentioned, and also some other reason why the patient is bleeding. Jennifer, any idea based on your experience at the University of Pennsylvania? I'm assuming you participated to their clinic there. In terms of and beside the platelets, have you seen or heard patient bleeding because of perforation after Lutathera treatment? We had some patient with a caking of the colon, so you can easily imagine if you're a perforation patient will be bleeding. Do you have any idea or any experience with that, or any reading?
So at University of Pennsylvania, I was involved in the therapies clinic, and they did a great number of Lutathera therapies, about 1 per day, and so about 40 per month. And we did not have, in my year there, any patients that had GI bleeding related to their tumors. We did have a few patients who had a large intraperitoneal burden who went on to have small bowel obstruction. Now, whether or not it was from the treatment that caused tumor swelling and the eventual obstruction, I'm not sure. On subsequent therapies, those patients were admitted, watched, and given steroids to try and prevent that from occurring again.
So Jennifer background is radiology, but I don't really see her as a radiologist. I really see her as a nuclear radiologist who is passionate for patient management. Jennifer, what would be your recommendation? We have people from the academic world, but we also have people from community household who I'm sure would love to get involved into Lutathera treatment. Or Lutathera was approved by Health Canada actually this past winter, I believe in January or February, and it's now reimbursed in Quebec and Ontario. Any recommendations to our colleague who are attending would like to start in the community hospital their Lutathera or their neuroendocrine tumor treatment program?
Well, I think that a multidisciplinary approach is really important. You know, even if you are fully set up and equipped to administer Lutathera, it's very difficult to get patient referrals if you don't have that connection with the oncologist, because that's who's going to be sending you all of their patients is the oncologist. And so, you know, we're working on creating a multidisciplinary tumor board at Wake Forest for this purpose, to make sure that we have a comprehensive group view on how to treat these patients and how to treat them best, and also to improve relationships between the treating members. Because I think that this really is a great therapy that is going to improve the lives of our patients. And there are so many things that we can do going forward. And if we open the doors for those communications, I think that we're going to make a lot of progress. So I guess my number one step that I would do is to, you know, find your gastro-oncologist, meet them, and, you know, talk about, you know, what is the number of patients that you're seeing that have neuroendocrine tumors, and are they something that you would want them to see us for this therapy?
Right, so Jennifer, as I said, Jennifer is an education expert. She was involved with the medical student. She's involved with the resident and the fellow. I'm going to ask the CANM office to send to the membership. Our next lecture is going to be on thermognostic educations at the IAEA, during the IAEA meeting and during the SNMMI India conference in December. Jennifer, thank you very much for this comprehensive review. And as I said, I'm sure that Jennifer would be more than happy to answer your question over the phone or reply to any email. Andrew, you want to take it from here? Thank you, Jennifer.
Well, thank you so
Thanks
very
very
much,
Jennifer. Thank you. That was excellent for everybody. I'll just say we are coming to the end of the morning session here. Hopefully everybody has gotten as much out of it as I have. It's seemingly gone flawlessly for most things, which is wonderful. There's a lot of moving parts. A lot of credit to the technical folks in the background, Nicola and Eric, pulling this together. So there are a few things. First of all, as the slide shows, for members of the CANM, this webinar will be available for reference and for review on the members section of the site. Once it'll give it a few days for the technical backup to kind of translate it over, but that'll be great. Understand, because of the way this system works, we actually have to use a different link for each aspect of this conference. So when we shut this off, that'll be the end of this particular link. There is the sponsors, the partnership industry lunch with some special treats going on. So hopefully you can get your box lunch from the kitchen and join us for that. That'll be interesting and entertaining for sure. But that is a separate link that you've got to click into. And then the PM session is again a separate link. So just if you have any concerns or anything with that, just chat with the question or ping the technical folks. They've been updating and doing things like that. As well, I want to bring, Nicola, if you could just switch to the next slide. Because some people may only be here for the morning session for logistical reasons. To get credit for this, this is fully accredited by the Royal College, and to get your precipitation, you need to fill out the evaluation form. It will be sent to you electronically in the next few days, and if you can fill it in and return it back, both for accreditation, but very much for our feedback, so we can take this forward. This is new territory, and hopefully it's going to continue to mature and help us deliver some content to you. With that, I think it's time to sign off for the morning. Jeanluc, do you have anything else you want to bring across?
No, thank you very much, Andrew. I think that is going to be a pleasure to reconnect this afternoon. I'm looking for more great lecture.
Absolutely. Nicola, do you have?
I will just like to thank personally all the speakers for their work. There was a lot of work in the previous weeks to make this as fluid as possible. So thank you very much for the rehearsal and their presentations today. Thank you also to the moderators. There was a lot of practice and rehearsal to make this happen. So quick thank you to you guys. For the lunch exhibit, the sponsors exhibit, I just want to tell everyone that you are more than welcome to join us for a fun lunch time. Like Dr. Ross just said, please grab something. We'll probably start in 5 minutes. So please go in the kitchen, make yourself a nice little lunch and come and join us. It's going to be a lot of entertainment. You previously received, if you registered already, on top of your email should be the link to join. If not, you have the link in the chat right now. And just to reiterate, like Dr. Ross said, for the PM session, it's a different link. You should have received your email confirmation with a new link for the PM. So please check your inbox for the email for the right links and join us in about 5 minutes for the sponsors exhibit. Thank you, everyone.
Thank you. See you shortly.
See you soon.
Nicolas, qu'est-ce que je dois faire ici?
Vous devez partir. Vous devez cliquer sur le X.